thank her for the work that she's doing, and then move to the next item on the agenda, which is indeed the planning guidance. I'm going to invite David Nicholson, the Chief Executive, to introduce the paper. David.
Thank you, Chairman. And I think the film that we just saw and the conversation we just had about capacity and practice is a really good beginning to it, because I think clearly regulation has its place in all of this, but regulation will not inspire and motivate staff to do great things for patients in that way. And in a sense, although this document itself is relatively dry, in a sense it's called the planning guidance, not something that in itself people would get excited about, I think it does signal some really important changes to the NHS and the way of doing things, which I think reinforce the points that Jane's been making through compassion in practice. I would ask people to go to the section after the preface, which has a diagram on it, which looks like this. I'm going to talk about this diagram here, which kind of encapsulates what we're trying to do here. And I would say, as a beginning, this is in my view, a remarkably radical document. In this document are some really, really significant changes in the way that the NHS will develop and the way in which the NHS interacts with the citizens of this country, which will have an impact in many years to come. And when you add this planning guidance to the conversation we're going to have on allocations, we are essentially setting the direction for the NHS for the next 5 years. So really important set of words that are in here. And what we've tried to do in the document, and this is why the diagram is, I think, so helpful, because it kind of works you through how the document operates. It starts with our overall vision: high quality care for all now and for future generations. So this whole planning guidance comes out of our unique position in relation to healthcare. And there's never been a national organisation like us in the past, which focuses our attention on the patient, on transparency, all those things that we know, and clinical commissioning, all those things that we know are really, really important. It starts off from the point of view of our ambition for outcomes, and outcomes in themselves can be expressed in all sorts of ways. But one of the outcomes, for example, in the arrangements is to have a good death, which I think relates, particularly to the film that we've had, to die in a place of your choosing, surrounded by your friends and family or whoever you feel is appropriate. So these are really important outcomes, which are not esoteric. They are actually real for people. So identifying the outcomes at the beginning and having some ambition for those outcomes is, in a sense, the start of the planning guidance itself, and underpinning those ambitions by improving health, reducing health inequalities, and parity of esteem. And one of the things about the document overall is that this parity between physical and mental health runs right the way through it, and all of the major issues in relation to this guidance relate both to mental health and to physical health. So they're a set of ambitions about outcomes, laudable in their own way, and have widespread support from our patients, from communities, and from the staff who work in the NHS. But what is the kind of service of the future that is most likely to deliver those outcomes? And that, in a sense, has been part of the work that we've been doing around the call to action, the strategy. And what you have next is a set of what we've described as service models, which are more likely to deliver the right outcomes for our patients. And they all are in themselves relatively simple to say, but are radical in the delivery. We've talked already about a new approach to citizen power in the sense of the NHS overall. Tim eloquently spoke about it earlier. The planning guidance has lots of examples of how we're going to make that a reality for the service as a whole as we go forward. it talks about primary care being more widely available and available at scale. In here is a set of proposals around giving incentives to primary care to manage patients in the community, to avoid admissions into hospital. There's an incentive scheme in here which will, in our view, have a significant impact both in terms of resourcing better primary care, but also making the changes required, and thinking about the way in which we move from primary care as a in some circumstances has been described in some parts of the country as a cottage industry into something that we can do at scale. If you think about some of the things that primary care will need to do in future, individual practices will need to work together across a bigger community and geographic footprint to make that a reality. So how are we going to make that happen in practice? A modern model of integrated care. In 15-16 we identify the Better Care Fund, £3.8 billion worth of NHS resource made available for out of hospital care, using concepts like the accountable clinician to make a reality of all of that. A big, I think, and significant step change in the way we deal with integrated care. The development of the work that Bruce has led on urgent and emergency care, right from reshaping 111, right the way through to identifying between 40 and 70 major emergency centres across the country who can provide top quality outcomes for patients across the system. A step change in productivity of elective care. There's lots of evidence now around the world that increasing your volumes and increasing the way in which you use the techniques that have been developed in other industries can make massive step changes in productivity, 30-40% improvements in productivity on elective care. So making that a reality is a big part of it. And then finally, for us particularly, the issue of specialised services. We identify in the planning guidance that we want to move towards between 15 and 30 major specialised centres across the country. We currently commission specialised commissioning services from over 300 organisations. So it's a massive and significant change. So if you add all of those things together, that is a very, very radical sense of direction for the NHS. We then in the document talk about those essentials that we need to do around access, quality, innovation and value to ensure that the basis on which all this is done is sensible. And then we go on to talk in the second part about how we're going to help the NHS deal with this challenge. And in a sense, it's the issue, the kind of the general approach here to think 5 years out, to think about what a strategy for service is radical in itself. We've never done that in the NHS before. So just for getting people to think about what the service would look like 5 years in advance is significant. So how are we going to help people do that? Well, we're setting out a planning process, a set of systems which will help them do it. We've identified a support package for people to enable and help the mechanics of all of this happen. And of course we're marshalling the work of improving quality, our quality improvement organisation, the Leadership Academy and the Academic Health Science Networks, all to support and help this happen. And I think taken together with a package around the allocations, this is a major landmark for the NHS and a major step forward.
David, thank you for that very clear outline of what it is we're proposing. I mean, I think the board will have a number of questions they wish to raise, but let me raise this first one, which is that if I'm the head of a clinical commissioning group and I see this coming in my direction, I know there's no more money, we're going to be held at flat real or a bit above flat real. What's the achievability of this, and how much of this will come as a surprise, how much of it will come as a part of a direction of travel to which we've already adjusted ourselves? And what's the extent of the challenge, do you feel, that this planning guidance sets for a clinical commissioning group?
Okay. I mean, the first thing I'd say is I would imagine that very little of this will be a surprise to clinical commissioning groups, in the sense that quite a lot of it has been built up over the last few months with people across the system. I think what will surprise people is how it's all brought together into one place. So I think that's the first that's the first thing. I think certainly being at the commissioning assembly, where we bring all the clinical commissioning group leaders together, they're as ambitious, if probably not more ambitious than we are, about some of the changes that they want to make. And in a sense, they look to us to provide them with the umbrella, the support, the help to enable them to do it. So I don't think there'll be any shortage of motivation and excitement about making all of these happen. I think the second issue, though, is more difficult, which is, have we got the capability and the capacity to make it happen? The NHS has never done this before, ever in its history. Anything like it, actually, in its history. And the old system would have struggled enormously to do some of this. And we know around, and this is not just an issue for clinical commissioning groups, it's also an issue for our own organisation. We've never done it like this before. And if you think about the changes in primary care, there's quite a lot for us to do. So we have to have those expectations. There is an iterative process in relation to the planning. So they'll be bringing up, people will be putting together plans. I think first cut is in February. We will have a better thing there. My guess on all of this would be about a third of our CCGs will fly with this, will get it and want to get on it. A third of them will be okay, and a third will need support. So we need to then, when we review the position in February, think about how we're going to use the support that we've got available to make it happen. And my guess is that we're going to have to do several iterations to get this in the right place. But that's the nature of the way of doing it.
Right, let me invite some comments from members of the board. Kieran.
I think that for me the support package is critical to this, because I love the document, I love the long-term view, love the parity of the steam, focus on outcomes, all of that. But it's the joining it all up for me which is challenging. So how does some of the system stuff link with the kind of compassion work with small change through the NHS change days? Because unless we get that kind of thing right, then the ability, the flex to have discretionary time, discretionary money in a provider gets really tight. So it kind of all links, and it's a really hard trick to pull off in any organisation. Major change is complicated, and just expecting people to be able to do it would be unfair. So for me, let's not skimp on the support package. Would be, content fantastic, but making it real and over focusing on support and offering it would be the critical success factor for me.
Your question was one I wanted to ask, and mine follows on also from Kieran's, really, particularly about local government and the speed with which they can contribute and be also supported to be part of this, really. The unit of planning might be worth commenting on, and how engaged they are with that would be useful to know, David.
Yeah. Okay, I'm sure Bill or Paul might want to respond to a bit of that. But it is, not only are we expecting clinical commissioning groups to do and ourselves to do a planning on 5 years out with a 2-year operational plan, which is difficult just in itself, there are also other levels. And so, for example, the better care arrangements are done at health and wellbeing board level. And of course we know that much of the, for example, on the urgent care stuff will be done on an even bigger footprint than that. So what we've tried to be is really flexible about the way both CCGs and local government come together at a health and wellbeing board level, and how they might want to come together at a larger geographic level in order to be able to deal with those issues. And we've had overall really good connection with the local government association, with local government generally. Clearly, they're keen to get the information out around the Better Care Fund and how that's going to work. And I think local government will be publishing their stuff on Wednesday, which we've worked very closely with to ensure that it's connected together. But I don't know whether Paul.
It's perhaps worth saying that in developing all of this planning guidance, we've done it absolutely hand in hand, not only with the Local Government Association and the other representatives of local government around the place, but with the provider community, because it's very important that this is planning which isn't just commissioner-led, it's integrated with providers. So both the Trust Development Authority and Monitor have been deeply engaged in framing this and ensuring that providers are ready to respond to that. Monitor has moved its own planning timetable to come into line with this, which is another a very important step forward. The planning assumptions will all be the same, and the units of planning that you've been referring to are the way in which that all comes together. And particularly for the strategic planning part of it, it's almost impossible to conceive of what we need to do here without those units of planning being alive and working. One of the key parts of the support package which we're putting together, Kieran, is the workshops that we're running to get those units of planning up and running very quickly at the start, because it just seems really important that the right dynamic is created in there before people set off doing the rather more mechanistic parts of the planning. For some communities, of course, that's work that's been long underway anyway on that basis, but we want to make sure that everyone is properly ready to do that. The other thing which is embedded in the second part of this document is a proper link to the change model, which we've perhaps not talked about very much in recent times in the board, but was a very important part of the way we developed as our way of working. And the change model for the NHS is absolutely central to the way we expect this to be done at local level.
Bill?
Thanks, Michael. Just to respond to a couple of those points. Local Government Association have been really excellent partners in the work ever since they were co-signatories with us on the call to action launch back in July. I think they recognise, the importance of really working hand in hand on this, and I do want to say thank you to them for that help. The 6 transformational models, these weren't sort of plucked out of thin air. So this has come through the set of debates, the engagement with actually international best practice to identify those big strategic changes that both satisfy our determination to improve outcomes and can realistically be achieved within the financial constraints we know we're going to have moving ahead. So these aren't trade-offs between quality and cost. That these are the strategic changes which allow us to do both of those things and therefore give the sort of headroom and space for the cultural work to go on alongside. So I don't see a trade-off. In fact, I don't think. I think we would squeeze out a lot of the really important cultural change if we weren't serious about the service changes that need to go alongside. I completely agree with what Paul says about capability and the points that Kieran made. I think that's going to be huge, and we need to be serious in our investment in support and capability. My expectation is since July, around the country, people have been thinking about these 5-year plans. It is something we told them would be coming there. My guess is they'll both want support for capability, for capacity, but out of this planning process will come a number of asks about what nationally, for example, on incentives, on financial arrangements to support change, what national measures we can take which will help them really accelerate the sorts of changes that communities and patients want and need.
Thank you. we're in a different world, aren't we? I mean, the CCGs have autonomy. Absolutely critical to how this gets implemented is that the fact that they have headroom. We will be resourcing them in the paper that we're about to discuss. We want to align properly those resources with clinical leadership and clinical judgment, and we want the CCGs to succeed, but we're not directing them on process. So what I would like, I think, is some discussion about how Part 2 relates to Part 1. Part 2 is quite a detailed planning structure for the delivery of Part 1. How far can the board be assured that what we've got in Part 2 will take us towards the delivery of Part 1? I'm not sure for whom that is a question. Is it for Bill, for David, or for Paul?
Well, maybe I can start to help with that process, because I absolutely agree with what you've said. So what we've tried to do is to give a structure which allows people to know what process to go through, but leave complete freedom for people then to fill the content of that appropriately. But the bit of the paper which is perhaps most critical to that is a bit that we're going to fill definitively later in the week, which is where we take the content of Part 1 and transcribe that into the series of questions which we want CCGs, and for that matter direct commissioners from the NHS England set up in localities. We want them to address those questions as part of it. So I think what we're trying to give is a bit of thought leadership as to what the big questions are that need to be addressed, and then give the CCGs and area teams enough space to answer those questions in ways that are directly relevant to their own communities, and with the support to do that in a professional way. That's how I think we will make the link through.
I agree with that. I think the connection's there. I think all that is set out in Part 2 is necessary for us to start this journey. I'm pretty sure it's not sufficient. So I would be astonished if over this period of months, the iteration of discussions in planning, if we didn't, through our own business planning, through discussions with other national partners, recognise that there'll be a number of very significant additional things, particularly I'd have thought around financing and incentives and allowing the headroom for change to happen, that we will have to identify and put in place to help get to the five-year vision set out in Part 1.
That is my... sorry.
Ed.
That is, I think it's tremendous we're going to go through it. The interesting thing that we will see, though, is the size of the gap. And I think the discussion around the board will be, so this is the ambition, this is the aggregation of the plans, but there's a gap. And it'll be a gap in terms of money, it will be a gap in terms of capability, and it will be a gap in terms of the time horizon in which colleagues want to get this done in the system, and the ability to drive that change. And I think, therefore, we're setting up a really interesting set of debates for us as a board over the coming 12 months as a consequence of this.
Yeah. Myra?
A different point. I just wanted to, I'm not sure who would respond to this, but to be reassured that this works as well for children's health as for adults and older people, really, because, you know, that the characteristics, as it were, as they're described, there aren't lots of mention of children. The finance director then.
It is, yes, I'm not sure it necessarily falls to the finance director, but I am responsible for the planning process as a whole. I think the simple answer is that we need a holistic strategy for each locality, and of course a holistic strategy has to cover children and older people, and it's got to cover physical and mental health in the way that we've just described. If there aren't explicit mentions of children all the way through it, it's not intended to limit the scope of what people should cover.
No, I think it's quite right. For example, two of the national events we ran, which are helping to come up with strategic changes around prevention and around parity of esteem, people with mental health, those were absolutely looking at, you know, the full range of people in our communities, you know, from children to the frail elderly. And I know Bruce's work on urgent and emergency care, likewise, has got an important focus on children as well.
Yeah. I'm sorry.
I was just going to say on children, and I think that the the kind of categories, the big 6 areas, children fall into those categories as well, and therefore we do need to accept that this is absolutely holistic. You know, sadly, some children are very ill and have very complex needs. Sadly, some of them have one chronic condition. We need to treat them as the active citizens, and the active citizens, that cohort of patients who are, you know, they're generally well, we need to keep them well, which is fortunately the case for most children. So I think you make a good point that we don't make enough mention of it, but I think out there in the communities they'll be looking to do just the same for people of all ages.
Kieran.
Picking up on Ed's point around GAP, the Better Care Fund, it's popping up in lots of places. You know, better support for carers, 7-day services. Is there a risk that it's the answer to absolutely everything and it won't really work?
I mean, I think every locality is going to have to make the choices within the Better Care Fund as to what's right for them to prioritise in that. I think the other point to say is that we talk about it in terms of the 3.8 billion that is being, as it were, required to be put into the Better Care Fund around the country. I think in many parts of the country there will be greater pooling than the 3.8 billion that we talk about. So where it's got life to it, that Better Care Fund, I think it can be expanded to fit the purposes that are needed of it.
But one of the big tasks for the Better Care Fund expenditure is going to be that it shifts significant amounts of activity out of acute hospitals. If it doesn't do that, it can't work. And it can do lots of things, but if it doesn't do that, it simply won't exist, because it is predominantly created out of this secondary care sector. So it's a kind of really hard-edged bit of the Better Care Fund, which is often missed, I think, as people get excited about the things. But unless it has a direct, and that in lots of ways is why it's really important that 14, 15 people start doing the things that will deliver that, because the idea that you can get to the 1st of April 2015 and then suddenly decide to take 15 or 20% of activity out of secondary care sector simply won't be credible. And so we'll have to watch really carefully throughout the year, and my guess is that some part of time during the year we'll have to make a judgment about whether it's deliverable or not, based on what's happened over the first 6 or 7 months of next year, in order to make it happen. Otherwise, we'll have real serious difficulties.
Margaret.
Against the use of the funds, obviously, and I completely understand why it is we're not recommending a model of integration, and we're leaving that sort of decision for the localities for themselves. But I think that if we're to be effective and to oversee and to understand that monies are being used appropriately, we ought really to be articulating measures and minima. And I think probably triggered into this thought by Moira's point about what about children, and if we're tying in the way in which we oversee with a huge raft of activity, we have to really articulate some sort of basic measures, and I just think that in order to enable the assurance programme to be clearer, we should perhaps be setting measures over the time period, so that when we look at Ed's list of the gaps, we can assess how we're closing them.
I just to answer on, particularly on your point about integration, I think, which is really important, because for me in the final analysis the only thing that matters is that the patient feels that the care they've received is integrated. I think we often get carried away with kind of integrated organisations or services being delivered out of one place or commissioners working together. So I think particularly on that, what we will have to measure is whether patients feel that what the care they're receiving is joined up, it makes sense. And I do think that across a range of services, the best way to do that is often very different. So it may be about two organisations working together, it may be about organisations coming together to create a merged organisation. It may be about integrated commissioning. But I think the only measure, if you're specifically talking about integration, is what the patient feels.
Okay, thank you. Thank you, David, for the paper. I know from conversations and, in fact, arguments that I've had with all the directors and national directors and non-executive directors that we all share the enthusiasm for the radical nature of these proposals. I think we're all nervous about their delivery. As a board, we would wish to have regular updates. We want to track the progress of this over the coming year to assure ourselves that this is a doable programme within limited resources and that it will produce positive outcomes for patients. But subject to that, may I invite the board to approve the planning guidance? Good. Thank you very much.